patient I had about 2 years ago now. He's actually a lawyer, cycling with his daughter in Jonkershoek, mountain biking. He came off his bike and he was moving his legs at the scene, obviously hurt his neck, and was sent to the local regional private hospital, and they assessed him with a C5-6 incomplete bifacet injury. So, this is working. So here's the MRI. You can see 2, 3, 4, 5, 6 is the area of dislocation. There's the spinal cord. You can see it's compressed over there. This shows you the facet joints on the one side. It's actually a facet fracture. You can see it's a fracture there. So it's a fracture dislocation, but he was incomplete. Okay? So on assessment, at 8 in the morning or 8:45, 4 or 5 power in his legs. It's good, useful motor function. 11 o'clock, dropping down, 2 or 5 power. They were unable to perform closed cervical traction. They phoned me, what can we do? So I said, send it through urgently. I was waiting at hospital. He arrived there at 2 o'clock, it was 0 to 5 power. I pulled his neck straight in 15 minutes. Okay? And unfortunately, I'll fix him the same day later, but he's never recovered. So he's a permanent tetraplegic now. And someone who was moving his legs at the scene of accident. This is what it's all about. It doesn't happen commonly. It's actually quite rare. But if it does happen, you can do something very significant to save these people's cause. And here's a guy in the prime of his life who's now in a wheelchair, completely dependent on everyone around him. So he remains a Frankel C, wheelchair bound. I can move his toe. It's very sad. So could we have prevented this? Would early reduction have helped? Is cervical reduction only limited to specialists, people working in level 1 hospitals? Imaging. You had a CT scan, you had an MRI scan. How long do you think it takes to get an MRI scan done nowadays? 2 hours, wait there for the radiographer to come out, put him in the trolley, moving his head around. What has that changed? What about urgent theatre? Should have got to theatre straight away. Okay, so when you're dealing with these patients, you need to make a diagnosis very quickly. Okay? Take a history. What's the mechanism of injury? Did you throw it out of a car? Did you fall off a bicycle? Do you have any neck pain? Neurological symptoms? Examine your patients. Okay? Very easy. Take the collar off. Long roll the patient. Feel from the occiput all the way down the spine. Okay? And you're feeling for tenderness, a gap. And at the end of it, of the spine, you don't put your finger in it, you put your foot in it. You do PR. Examine the patient's sphincter for voluntary pinch and for sensation. And appropriate imaging. This is from American Association of Neurological Surgeons, their guidelines. So patients following trauma who do not need imaging, patients are normal neurologically, patients who are not drunk, so it rules out 90% of our trauma patients, patients with no neckline on the middle neck or midline tenderness, and patients without an associated injury. These are the nexus criteria, a lot of you know this. These patients do not need an X-ray. You can rule out a neck injury clinically. Okay? When we ask for X-rays, we ask for basic views. Obviously, a lot of trauma centers got a CT scan now, which is very rapid acquisition. It's quite nice. The patient doesn't have to sit up, you have to turn them. And obviously, everyone's got an MRI to throw as well. X-rays, apilateral open mouth. That's all you need to make a diagnosis. Okay? You must be able to see the C7 T1 level. If you can't, we ask for a swimmer's view or the flying angel view. The lead views aren't necessary. A CT scan, you can pick up some injuries you don't see on an X-ray. Most notably, the facet fractures can be very subtle fracture. They're very quick in the standard of care in most hospitals. To my mind, haven't actually replaced the X-ray yet. We had a prominent German surgeon out a year or 2 ago saying they don't do X-rays anymore, just CT scans. All that's unnecessary. Okay, a lot of radiation, and the patient's got a bit of a sore neck. Okay, so you must have an X-ray. If you're not sure what you're seeing in X-ray, or it's a difficult neck with osteoarthritis, fine, get a CT scan. It doesn't replace it, in my opinion. There you can see a CT can show you the facets facet fracture there. You may not see this fracture on an X-ray, okay? And it shows you these facets are pushed. Okay. MRI is used to assess the soft tissue. So you can see the spinal cord, you can see the nerves, and ligaments. It's more sensitive, but it can miss injuries. You often may not see a fracture in MRI. And it's got a high false negative rate for ligamentous injury. So the ligament might look intact in MRI, but if you do flex X views or dynamic views, there's instability. So there's an MRI of this patient. You can see it shows the cord compression there, some disc there. Looks like there's a separation of the ligaments at the back. You can see there's a facet there. That one is pushed in this facet. You appreciate it? There's a nice rhomboid facet there. That should be sitting overlapping this one, like these two are overlapping. So it's slipped forward and it's not pushed, or tip to tip. X-rays, don't forget with nice easy lines. You start off, the first line is a soft tissue line. There you have a nice soft tissue line. If you intubated your patient, you can't rely on this line, it's not accurate. Okay? Or if it's a crying child. So normally the line is quite thick around C1. So we talk about the rule of 10, 5, and 15. That's what could agree. In general, you don't want to have the swelling, the soft tissue more than body thickness down below C4, okay, or C5. In front of C1, you are 10. You're looking for a swelling. That's what you're looking for, okay? It's quite thin in the front here down to C3. Next line is the anterior body line. Follow it all the way down to make sure you go to T1, okay? Looking for a step. And the posterior body line, what's the next line? On a lateral line, eh? That's it there. If you're not sure where it is, because remember the facets can be confusing, eh? If you're not sure it's what. Look at C2. C2, you don't see the facet line very easily. Is a clear, and that's between the base of the spinous process and the lamina. So this space, that line, is where your cord runs, exactly in that space. See how nice and wide is on top of the cord? As you run down, it's less space, okay? So often that's why your axial injuries are on the C1 ring and the C2 peg. They don't have neurological injury because there's a lot more space for the cord, okay? And that's the last time you look at is the lines of convergence, okay? And that really draws the eye to lordosis of the neck. The lines should all converge to an imaginary point in space. And if we have a dislocation, the line will be divergent at that point, okay? So it's just a nice way to draw your eye to segmental kyphosis. Other things in the lateral you look for, make sure the disc spaces are sort of equal, that the body's all nice and square, not fractured. You need to appreciate the peg. So it's an ADI, adventitious dense interval, should be less than 3.5 millimeters in adults. The back of the peg should be a straight line running up the back of the body of C2. It should be a straight line. If you're not seeing a straight line, you must appreciate there may be a fracture of the peg. Also, the spinal lamina line should follow a nice arc. If there's movement up here, this will be a step here, okay? There's a clivus. The clivus points towards the tip of the dens. There's a ligament on top here. In children who may have a craniocervical dislocation, this may be displaced, okay? So it's just a picture showing you the space of the cord between the spinal lamina line and the back of the body line. Open mouth view will show us a peg, will show us the lateral masses. We have outlined the peg. And the lateral masses of C1. If there's a Jefferson fracture, so there's an impact on the head and axial load, it will splay the C1 fractures and will displace laterally. If the combined overhang is measured is more than 6.9 millimeters, it means the transverse ligament has been ruptured. That's what we look for in the X-ray. Also on the AP, you must appreciate the spinous processes, okay? If there's rotation, they'll rotate like that, okay? And that's what you see with the unifacet dislocation. Okay, the other facets, now on the lateral X-ray and a true lateral, the facets all nicely superimposed, they're like little trapeziums. There's no double shadow. As we get further off where the X-rays focus on, you'll start seeing a double line. So there's a double line there, and maybe a double line around a bit. Where the X-rays focused here, it's a perfect little rhomboid, okay? There's two facets here. So you can schematicize them like that. And The body's on front, little squares, and there's two facets, so there's two perfectly overlapping rhomboids. Okay. If you rotate the neck, or you take an oblique view, they move like that. Okay, that's an oblique view of the facets. They'll also be symmetrically rotated. So I'll turn my neck in X-ray, they'll look like that. And depending on where I'm turning from, so there'll be more rotation on top and less as we go down. Okay. With parallax, they tend to move like that. So if the X-ray beam is focused up there, like C1, they'll be moving, they'll be separating in this fashion because of the error of parallax, not because they're rotated. All right. Rotation is only motion in this plane. So if we look at this X-ray here, we can see soft tissue line. Okay. There's a step, an anterior body line, posterior body line's got a step. Spinal laminar line coming down here. I see maybe a step. Lines convergence. Look at that big gap separating. Okay. So it might seem obvious, but you know, time and time again, you seem to see the picture now of what it is. Okay. And this is obviously a dislocation. There's no fracture here, so it's not a fracture dislocation. And let's look at the facet joint. So if I think this was dislocated, it's C2, 3, 4, and 5. This is C5 here. Let's look at C5 facets. There's a facet there. Is there anything above it? No, it's empty. So there's one facet there. But it's not a nice lateral X-ray. I'm seeing another facet here as well. Eh? Whereas here I'm seeing two facets side by side. So the rotation I'm seeing is below. So obviously the X-ray is taken perfectly lateral to this part of the spine, but not to this part. Eh? There's the facet joints. Eh? These aren't rotated. These are rotated. One facet is touching. The one facet is empty. So it's a unifacet dislocation. Another X-ray. You look here, we can see spinous process seems to be in the middle here. Maybe there's some movement here across, I don't know. Lines are disrupted, there's a dislocation. I'm seeing two facets here. You can see there's a facet here and a facet there. Maybe bigger. So there's no rotation here, there's two facets and only one is sitting on top. Eh? So it's like that. The unifacet dislocation. There's a bifacet. In a bifacet, we don't expect any rotation. And also the bifacet, because both facets are unhinged, there's no limit to how far the body can translate. So your bifacets tend to be more than 50% translation. There's no facet joint holding it back at the back. Right? And I'm going to zoom in. I can see outline of two facets. There's one and there's the other one there. There's no rotation here. Over here, I'm seeing one facet there, another facet there. So we're seeing, no, didn't draw there. So it's a bifacet dislocation. With this picture, so if you have a fracture dislocation, it's a slightly different kettle of fish. Here we can see there's obviously dislocation here. The bodies don't look fractured, so why am I calling it a fracture dislocation? Here you can see two facets, you agree? And here's two facets. I'm seeing two facets here. Two facets, there's no rotation, okay? It looks like there's a tip of this facet there, so it's completely dislocated. It's not pushed. Why am I calling it a fracture dislocation? Let's look. Anterior body line, got a step. Posterior body line, got a step. Spinal laminar line, it's not a clear-cut step, is it? So there's a spinal laminar line, and there's a posterior body line. So it means that this spinous process has stayed behind while the body's come forward. So it must have fractured between the spinous process and the body. It's a fracture dislocation. Okay? You see a lot of detail on X-ray. It's a unifacet dislocation. These two facets are beautifully lined up. See both very perfectly lined up. Here I'm seeing two facets. Okay, there's one there, and there's one here. This one is still touching on top, so it's not dislocated. This one's come forward. Unifacet. So you can make a diagnosis in X-ray. If you have a CT, great. You don't have to have a CT scan. Okay. Early spinal alignment. Any broken bone orthopedics, if you have a displaced femur fracture or a displaced ankle fracture, you pull it straight. Spine's no different. Okay. You want to align the spine. Different ways of aligning a spine. You can do closed reduction. So you can sedate the patient, do anesthetic, pull the neck straight. That's called manipulation under anesthesia, or you can do gradual traction with the patient awake. Okay? You don't ever want to pull a neck straight with the patient asleep or paralyze them. Okay? It's very important. The patient must be awake and cooperating. You can do open reduction of the neck from the front or the back or both if you want to take the surgery. This course is about the safest way of doing it, which is gradual traction reduction. Okay. Why do we do it? So we're indirectly decompressing the cord. Obviously, if you've got a canal and it's desiccated, it's pinched. So if you line the canal up again, the spinal cord is not compressed anymore. Maintain alignment. You want to prevent secondary injury, like a poor patient I showed before, he was moving his legs. A few hours later, he was paralyzed. That's what secondary injury does to a cord. We want to try and improve neurological outcomes. When do we put traction on heads? Okay, so C1, C2 rotatory subluxation, the so-called torticollis. You might see it in children. Displaced peg fractures. You have to put them in traction to align them. Hangman's fractures, and any fractures of a neck with malalignment. We put skull traction on the head to line the neck. Why do you have to put traction on the skull? Why not just halter around the patient's neck? Well, it gets sore. You can't open your joint or your jaw, you get TMJ problems, and the patient can't breathe, so it's easier to put pins in the head. Okay? And it's very safe. These are all displaced fractures or unstable fractures. We're maintaining alignment. Okay? We're putting the neck in line with 5 kilograms of weight. Your facet desiccations, they are slightly different. They are an active reduction process. Okay? It's very different to maintaining alignment. So there's your torticollis, your C1, C2 rotatory subluxation. There's your displaced peg fracture. Look at the back of the line, it should be a straight line. It's displaced forward. There's a traumatic spondylolisthesis. There's a fracture C2 pars with a step. There's a subaxial burst fracture. There's a step break in the line. These are all unstable or displaced fractures. Those you put pins in the head, you pull 5 kilograms in line, you stabilize the neck. This is a dislocation. There's no fracture here. This needs an active reduction process. Reduction restores the spinal alignment, eliminates bony compression of the cord, and prevents further damage. Okay? Time's really important here. The cord is dying before your eyes. You can see how the cord gets pinched between the back of the lamina here and the inferior vertebrae supracorda. Animal studies and human studies show that early decompression allows neurological recovery. There's a whole lot of animal models which explain why we get this, why we need to reduce the compression. There's very convincing evidence that compression is a reversible form of secondary injury. We can reverse the injury. Okay, in fact, if you don't have decompression in the first 3 hours, you may get irreversible neurological damage. And in fact, it seems like the first hour is the most critical for decompression of the cord, never mind 4 hours. In humans, we haven't got any good randomized controlled trials, but all the evidence points to patients having improved neurological outcomes with early reduction. There's the Staskis trial. It's an enormous trial looking at early reduction at many centers in America over 7 years. And they looked at changes in the Asia impairment scale, which is your neurological grading scale. And they found that decompression in the first 24 hours is safe and gives improved neurological outcomes. Okay, so all the evidence is pointing that the earlier you do it, the better. This paper by Dr. Newton is really what started the whole Constitutional Court ruling. It's not the most scientifically rigid paper, but it's the only one out there which has evidence for early reduction. Okay, so until someone can come with a paper and say there's no reason to not do it, this is what stands. Okay. 57 rugby players, you find the bifacets of one injury which shows benefit. These are patients that are coming in. So this is patients, this is time to reduction. So 1 hour, 4 hours, these are 5 hours. So this is admission. So these patients are Asia A's. These are Asia's 1, 2, 3 Asia A's, 4, 5, 6, 7. all Asia A's, okay? That means that no motor and no sensation in these patients. On discharge, look at them, look at neurological differences. Look at this one, E, okay? So they amazing amount of neurological recovery within the reduction within 4 hours. After 5 hours or so, there's no change, real difference. Okay, all the same. 12 hours, no real change in your thing. This is one outload, 11 hours he was reduced and he managed to recover, so he's lucky. So, in order to prevent permanent neurological damage after rugby injuries, cervical fascial dislocations should probably be reduced within 4 hours of injury. And that's what the course looked at. What about closed reduction versus open reduction? So, we know that early decompression gives you better outcomes, and would surgery not be quicker? Just go and operate on the neck. So, it's very hard to do an operation within 4 hours. I mean, you have patients wait several hours on the emergency board. It takes you 2 hours to get your MRI done, at minimum. Okay? You need to get the theatre ready, prepare the staff, get the sets in, set up the patient, put them to sleep, make sure they don't get hypertensive, get the leads going, position the patient. You won't get an operation done in 4 hours. Impossible. Closed reduction can happen within 15 minutes. Okay? So there's no comparison. So, is it safe? This is from American Society of Neurosurgeons again. They looked at 1,200 patients treated with closed reduction. 80% was successfully reduced. The chance of making someone permanently worse is less than 1%. It's extremely safe. Okay, so closed reduction is safe and effective. 80% of the time you're going to get the neck straight, and less than 1% chance of making the patients worse. What about MRI? I think you need an MRI to do safe closed reduction. So you have got a patient's dislocation, you can see the disc is rolled up behind the vertebral body, and everyone's worried about this when you pull it back. So here's the problem is that the surgeons, we can't seem to agree whether he wants an MRI or not. Here's 25 fellowship trained spinal surgeons, no consensus to get pre-reduction MRI or not. And what do you do after the MRI? Now do you change, okay, I don't want to reduce it close, like I've seen the nasty disc, now I'm going to go to theatre, it's going to delay me more. So it's very contentious. So what's a disc herniation MRI? So any disc which protrudes posterior to a vertical line behind his body is a disc herniation. This disc is not herniated. It's lying behind the body, but it's not lying posterior. If you think about it, this space between this lamina and the body doesn't change whether the body's there or there or there. That space doesn't change. So you can reduce the neck, this distance between the lamina and there and the disc stays exactly the same. It just moves backwards. The facets have been relocated. And that's probably why it doesn't change. There's a lot of interreliability errors with interpretation of MRI scans. And the problem is it affects behavior. At Kruger Cervical Hospital, we looked at 19 patients that had a so-called disc at risk. That's a disc lying posterior to the body. 13 went closed reduction, and none of them deteriorated. The study looked at what happens to the cervical disc during a closed reduction. So 18% of these patients had a disc herniation before reduction. After reduction, 56% had a herniation. No patient deteriorated. Makes no difference. And we know that of these patients, 1,200, half of them would probably have a disc prolapse. No patient deteriorates after reduction. Only less than 1% of the time. So it doesn't matter what the disc is doing on MRI. It doesn't affect the clinical outcome, but it may affect your surgeon behavior. And it takes time to do. Why is the risk of neurological deterioration so low? We accept there's a high incidence of disc herniation. We know that neurological deterioration is very rare, less than 1%. It's thought that traction reduction may partially reduce the disc extrusion. These guys looked at the disc during reduction. There's a fragment of disc lying there. And pre-traction, a lot of discs were disrupted. Afterwards, they found less discs were herniated. And they thought that the traction somehow seems to reduce the disc. So if you're pulling on this, it tends to pull the disc back into place and reduce it. Whereas if you just reduce the neck without traction, you can sweep the disc in the canal. I'm not sure I fully agree with that, but we know that the incidence of neurology is very, very low, even with the disc problems. MRI is risky, delays your treatment. You've got to move the patient in and out the MRI scan. We've had at least 2-3 incidents of the patient redislocating in the MRI scan, moving him. Also, once you got an MRI, now you're too scared to pull the neck closed. You don't want to go to theatre because you see the disc at risk, even though it's got no clinical consequence. There's a lot of delay to MRI. These doctors find 4 or 5 days before the patient got an MRI scan. It's a very scarce resource. So our feeling is that MRI should not be done with a neck dislocation. And we can discuss later under what circumstances you should do an MRI scan. So in South Africa, we're the only country in the world with a legal precedent saying we have to pull a neck straight within 4 hours. It's the Constitutional Court judgment in 2015. I'm not sure if it's going to play. So your head almost bumps against your belly button, eh? It's almost want to force to roll around. So what you do to your neck is a bit of traction. That the kilograms is nothing compared to what the neck has been through. So this is Mr. Oppels in 2002, sustained a spinal cord injury in a rugby match. He went first to Westcliff Hospital, and then was transferred to Kruger Cervical Hospital, eventually ended up in Conradi Hospital. And his reduction was 14 hours after his injury, and he was left permanently quadriplegic. So he instituted a claim, negligence against the Western Cape High Court. He claimed that the hospital personnel acted negligently by failing to treat him within 4 hours of his injury. The court then looked at this paper by Dr. Newton, and who concluded that patients with cervical dislocations with a low energy impact have a 64% chance of complete recovery. So, look, it's not great science, but he has got the only paper which shows 7-8 Asia A patients walking out Asia E after reduction. Okay? It's very hard to argue against it. And he concluded that the applicant would not have been quadriplegic if he'd been reduced in 4 hours. The High Court thought this was well reasoned, and there's no evidence to the contrary. It found the delays were unreasonable, and concluded he was refused emergency medical treatment and awarded damages. The Department of Health then appealed to the Supreme Court of Appeal, and the Supreme Court thought that Oppels had failed to prove the validity of Dr. Newton's evidence, and they reversed the decision. So never give up in life. You go to the Constitutional Court. The Constitutional Court accepted Dr. Newton's evidence and found that his paraplegia could have been avoided if he received appropriate treatment promptly, and then found that the Department of Health was negligent and violated the patient's right to emergency medical treatment. It found that treatment is cheap and could have been performed promptly. Or 19 million rand to Mr. Oppels. So, in South Africa, the highest court in the land has decreed that low, I'll say velocity, but it's probably low energy, cervical dislocations need to be reduced within 4 hours of injury. Okay, so these are the key points so far. Eh? Make a diagnosis and X-ray. Early alignment is important. Close reduction is safe and effective. Don't do MRI. We have a law saying at 4 hours. What about delays to reduction? So, delays are from an accident scene to hospital ER to referral, and a specialist referral to reduction. Western Australia, one tertiary centre and referred from these rural centres. Reductions only happen in a tertiary centre. It's sort of like rescue hospital. Their closed reduction time in urban areas is 10 hours. If you live in the country, 27 hours. That's in Australia. You've got poor Africa trying to hobble on, trying to keep up. There's another one, also Melbourne, ER to reduction. So from arriving in ER to reduction, 6 hours. Their waiting time for MRI in Australia is 5 hours. Kruger Hospital looked at their cervical reductions. They found the ambulances took 3 hours to get from injury to ER. I don't strictly believe that. The trauma unit time to refer to orthopedics took 14 hours. So you get a patient lying there, dislocated neck in a trolley, 14 hours to pick that little tidbit up. Orthopedics reduction, 14 hours. Long time. So these are realities on the ground. So lots to do in 1 hour, eh? From injury to ER. If you accept the ambulances take 3 hours to get you, which I don't think is right. 1 hour to fix everything up. Get your patient, history, examine, discuss, consent the patient, find your cones, calipers, find the rope, the weights that haven't been stolen, find your local anesthetic, find a bed, double mattress, get your monitor going, find a nurse, apply the cones, form reduction, 1 hour. Okay, cervical dislocation should be managed as cord-saving procedures. Okay, so let's go through a bit of reduction for dummies. First described in 1983, a guy called Crutchfield brought his tongs in, used these doctors popularized an anesthetic. Yes, of course, you can reduce an anesthetic, you're going to paralyze your patient. The patient must be awake. These are a variety of tools. These are Crutchfields. They really clamp right on the top of the skull. Not particularly useful. If you've got a pair, throw them away, they're useless. Don't work. They'll pull out. In fact, you get them to engage so hard they won't slip off, you're going to probably fracture the skull. These are the Rolls Royce of reduction tongs, okay? They're called Gardner Wells. You've got a torque limited screw, which sits in the head, and the angle makes it very difficult to slip off, okay? Unfortunately, we don't have them. We've got the old cones calipers, which do okay if they're applied properly. And hopefully I'll explain to you how to apply them today. They'll come in a packet like this. There should be a spanner in the packet, but of course, it's Africa, we don't have spanners. They're pinched. They come with two little pins. The pins are supposed to match this barrel, they don't always match. They work by opening like a scissor. There's a bolt at the back which you open and close. It's called open the tongs and open the front. And there's a lock nut there. A little insert, the pin, it's got a section. There's a spanner you're supposed to have, which you can open the barrel at the back. I think it's a size 10, am I correct, Judith? It's a size 10 spanner. Yeah. So opening and close this nut to the back will open and close the tongs. You have different barrel shapes and sizes, and obviously the pin for this one won't work in this barrel. It has a pin, so you get a smooth shaft, and you get a threaded bit, and that's for your spanner to turn, and they turn in and out like that. You want this tip of the pin to protrude 3 to 5 millimeters out the end, because that part goes in the skull. Okay? The spanner's got a little slot which locks in the back of the pin and allows you to turn the pin backwards and forwards. As such, to do a closed reduction, you need an awake, cooperative patient. You can't be fighting, you can't be holding him down. Okay? You need to provide constant neurological and physiological evaluation, and it's performed by an experienced clinician who has a heightened awareness of potential complications. Okay? Not a specialist, not a spinal surgeon, a clinician, okay? A doctor. When can't you do it? You must have the right diagnosis. Okay? Make a diagnosis. Unconscious, uncooperative patient, you cannot do closed reduction. The skull fracture, it depends where the fracture is. If it's a base of skull fracture, probably not the best idea. Infection or degloving a scalp is a relative contraindication. You'll need a bed and double mattress, a C-arm, because you need to monitor and X-rays what you're doing. You need the reduction equipment, and SATS monitor, IV line, and some sedation. And we've got some orthopedic rope. We've got this is called a swan neck pulley. So basically, it's got a pulley there, which has got a long neck, so you can raise the pulley or lower the pulley. Your tongs, your bed, weights, and a weight spike. You're going to put the patient supine, neck in neutral position, double mattress, and you can put the bed in reverse Trendelenburg. Why are we using a double mattress? Don't say bed sores, please. Because normally lying, the head's pushed forward by the occiput. Double mattress allows us to extend the neck if we want to, okay? We're going to use the body weight as a counterbalance, so it doesn't pull the patient off the end of the bed. So we can elevate the bed. Now, you'll find that your bed can only go into Trendelenburg. That means legs up. Can't go over around, so you might want to turn the patient around the bed, okay? Just checking that. You're going to shave the area to above the ear. We're going to put the pins, keen some alcohol or iodine, inject some local anesthetic, inject it straight down onto the skull, and use Marcaine or lignocaine with adrenaline. And so inject straight on the periosteum and lift it up and raise a bleb under the skin. Very easy. What are the landmarks? So the ear hole, luckily enough, is in line with the middle of the spine. Okay? So you want to be in line with the ear hole, your external auditory meatus. That's your line where your pin goes. If you go too high, you're above the equator of the head, the pin can slip off. So you want to be low enough it doesn't slip off. But not so low you want to go through the ear pinner. So all you want to do is make sure the pin is not done the ear pinner. So put a finger above the tip of the ear, in line with the ear hole, that's where you're going. That's your landmark. Cannot be simpler. The only thing you might worry about is the temporal artery, which is quite in front here. You don't want to be there. You may have an aberrant loop of artery, so palpate the artery, see if you can feel the pulse. Not so hard, okay? So here got some equipment, got a sonic pulley. The patient's had a bit of the head shaved here, in line with the ear hole. That's our vertical line. Injecting down onto the skull and raising a bleb. You make a vertical incision. Don't make it horizontal. Don't try and cross the temporal artery. A vertical stab, it's literally a centimeter stab. And then using a blunt artery, an artery forceps or a scissor, blunt dissect down onto the periosteum, okay? If you do get profuse bleeding, just put some pressure in for a couple of minutes or so, it'll stop, okay? Then you apply the cones. So once again, key points, in line with external auditory meatus. They say 2 to 3 centimeters. A finger's fine, unless you've got terribly small fingers. Palpate the temporal artery, vertical skin incision, blunt scissors dissect down to periosteum. What's wrong with this picture? Here's the ear hole. It's too much in front, eh? This is your petrous part of your temple bones. Nice, hard bone. Remember, petrous means stone. If you wander too far anteriorly, you come to the squamous part of the petrous bone, which is much thinner. The petrous bone here is about 15 millimeters thick. It's plenty thick enough for a pin. Too high and too far forward, eh? You'll be in line with the ear hole. There. Also note that the pin must penetrate 3 to 5 millimeters into the skull. So, first of all, check your pin is the right fit for the barrel. Maybe with the wrong pin set, might be too long. So turn your pin all the way in to check that it only protrudes a maximum of 5 millimeters. By swiveling the spanner, we can drive the pin in. Okay, so here the spanner has been tightened, and you apply your barrel to the hole. So there's a bit of a technique here. You want your barrel to lie on the skull, okay? The barrel must be lying on the skin, if you're lying on the skull, and just the pin penetrates the skull. You don't want this picture where the pin doesn't penetrate at all. Yeah. The barrel's lying on the skull, that can slip. Also, look at this pin. The pin's not even fully in the barrel, so obviously the wrong size pin for this barrel. And the barrel partially turns out to make sure it doesn't protrude too much. So, What I suggest you do is put your pin all in the barrel, full, and check it's no more than 5 mils, okay? You apply the cones onto where your holes are, you tighten them up to the back, so it's tight. So the pin will be sitting tightly in the skull. It's not going to suddenly cheese away off in the bone. The bone is very, very hard, but it's sitting tight, you tighten them up to the back. Then what you do with the spanner is wriggle the spanner backwards and forwards, not all one way or the other way, just backwards and forwards, so it's under tension, the pin's moving, it will cut into the bone. Retighten the back, because as the pin cuts in, your device is going to lose tension, so retighten the back, carry on, until you feel the pin is down, okay? Take the head and give it a good hard pull. You should not be able to pull it off as your strongest pull, okay? Pull as hard as you want, it should not come off, then you know you're fine. If it slips, reapply the pin. You put your weights on over your swan neck pulley. So this is a swan neck. So a clamp down here, so you can, by loosening the clamp, you can lift the pulley to pull up. So you can pull up in flexion, or you can drop the pulley down to pull down in extension. There's our pulley, got a weight on board here. How much weight? So there's no literature on this. Dr. Newton used to start with 60 kilograms. It's a lot of weight. And understand that there's a chance of neurological deterioration. There's lots of formulas. You can add 10 pounds to the head and 5 pounds per level, and then increase 2.5 pounds. There's all these don't make it complicated. It's very, very simple. You're going to start with a small weight to check that you're not getting over distraction. Once you're happy with the X-ray, it's not over distracting, you're going to increase by weight until you get to your target weight, at which point the facets desiccate, or they line up. That tends to about 35 to 40 kilograms. Okay? So you increase weight until you get close reduction and realignment occurs. Unless the patient starts complaining of terrible pain or neurological worsening, or you see over-distraction on X-ray, or you run out of weight, or you decide you've had enough. Okay? Start with 5 kilograms, take a check X-ray. Then flex the patient to 20 degrees, 20 to 30, it's a bit of a thumb suck. Increase 5 kilograms every 5 minutes. 5, 5, 5, easy. Every time you add a weight, do a neuro exam and a check X-ray. You shouldn't really go past 40 kilograms. If your pins are placed properly, you can go much higher. I've gone to 60 before. But 40 kilograms, if you've gone to 40 and the patient hasn't reduced, probably not reducible. You probably 20% of the time it won't reduce. As a neck, there's a dislocation. It looks like a unifacet. I see 2 facets nicely lined up here. These 2 are rotated. It looks like this one is the empty facet, so it's a unifacet dislocation. Eh? Why do we flex a neck? Remember your soft tissue structures in the front act like a tether. So if I just pull, it's not showing. If I just pull, this will act like a check rein. I'm not allowed to pull properly. It's almost like a green stick fracture in a child. You've got to make an injury worse to hitch it on. So by flexing the neck, you flex it, it gives us some slack in the ligaments and allows us to disimpact the fracture. Okay? So that's why you flex the neck. Don't flex too much because you're pulling a cord over the virtual body. So you're going to flex no more than 20 to 30 degrees. Okay? And that's reduction process. Okay, so you start there, we add 5 kilograms. Check it's not over distraction here. If you're all happy, proceed. We then flex the neck by raising the pulley 20 to 30 degrees, increase weight until the facets are tip to tip. Now what do? We drop the pulley down, extend the neck. You're still under a lot of weight here, still under 40 kilograms. What do you do next? Reduce the weight to 5 kilograms. Couldn't be easier. Once you have reduction, extend the spine, reduce to 5 kilograms, take a check X-ray. Our endpoints of reduction: worsening of patient's neurological status, over distraction, failure reduction. You might get a 40 kilograms and there's no reduction. What are the complications? So there's a couple described. Patients can deteriorate neurologically, Vertebral fracture, you may convert unifacet to bifacet. Most commonly with pin slip, most commonly you get your target weight and you have to reduce the neck. Don't ever do GA, patient must be awake. Their brain is your neuromonitoring of your spinal cord. If the patient's unconscious, you've got no monitoring. Once again, 1,200 patients, less than 1% get the worst permanent. Very, very safe. Safe in driving the car to hospital at night. Here's a patient with a dislocation. Form 5, you can see the disc is not behind the body. There's a cord signal here. There's a facet dislocated there. That one's perched. Here's under traction. See the pins are on in line of the ear hole, in line of the spine. See it? Beautiful. Okay, so it's flexed. Okay, and increasing the weight, 20 kilograms. You can see the facet looks like the one's perched, the one's back on now. And over here, both facets are. Looks like they're at least lined up. It looks like if you extend the spine, you'll go back. Here we go, extend the spine. 5 kilograms. Nicely reduced. Nice and easy. After you reduce the neck, you need to operate them to stabilize it because there's about a 33% dislocation rate again. It's a disco-ligamentous injury. It won't heal up properly. But you can do this operation at any point. There's no rush. The patient can be sent to the next province you want, as long as his neck's reduced. There's no urgency after that, because the cord's decompressed. Here's a young kid, 16-year-old schoolboy, had a rugby injury 2 hours ago. He's a Frankel C, which means he's got useless motor function. He's obviously got a neck dislocation there. So, what's the diagnosis? So, my lines are disrupted. I've got a step there, no fracture, it's a dislocation. I'm seeing 2 facets in nicely. I'm seeing 1 tip there. Other tip is lying, other facet is lying here. Unifacet dislocation. I don't need a CT scan. I don't need an MRI scan. How are you going to treat this patient? Cervical reduction. Okay. There's our facets. We don't want an MRI scan. It's not going to do, it's not of any value. It's going to delay our reduction. You had an MRI scan. Show the disc. This is really for surgeons, so I want to answer this. Okay, so this patient, after you've seen this MRI scan, would you still reduce the neck? We know that the literature said it's safe, don't we? As long as the patient's awake and we monitor his neurology, okay? So you need to be able to put the reduction on. ER doctors, registrars, orthopedic doctors, neurosurgeons, use the people who we think should be reducing necks. We think every single doctor must have his basic skill, okay? Same as every doctor needs to be able to intubate a patient or do an ICD drain, they must be able to do neck reduction. When the patient comes in an Asia A, he's a complete neurological deficit. You can't make him worse. There's nothing to lose to these patients. Okay, cervical dislocation is a cord-saving procedure. I looked at the state of cervical traction in the Western Cape, and it doesn't make for good reading. So I did an ethics application form. We looked at all the hospitals under the government website. I sent them questions. Does your facility have any protocols for the management of dislocation? 80% said no, no protocols. Does your hospital have cones calipers or C-arm? 57% no cones calipers. Have you ever had C-arm doctors ever had training in cervical reduction? Almost half no training. I gave a scenario of a patient with different scenarios. What's the main indication to reduce the neck? And 86% of doctors identified that as a patient with deteriorating neurology. I gave a scenario of a patient with a dislocation who's deteriorating neurologically, and I asked what would your immediate action be. 55% of doctors would rather refer the patient on accepting a 2-hour delay in treatment. Mind-boggling. What do you feel is the risk of making the patient worse neurologically during reduction? Only 10% think it's safe. Most doctors think it's unsafe. I asked if any of those hospitals have a spinal surgery trained or experienced orthopedic surgeon or neurosurgeon to help. Only half of them have got a specialist around who can help. And I can bet your bottom dollar, 90% of the specialists wouldn't be able to do it. I know, I don't say everything. Would you change your clinical practice if you're training? Most people would change your clinical practice if they're training and be comfortable to reduce the neck if they had to. There's misconceptions. It's dangerous, you need an MRI scan, it's a specialist procedure. You know it's not dangerous. The literature tells us 80% successful, there's a 1% permanent neurological worsening. It's safe and effective. You need an MRI scan. MRI is useful, it gives you information on the spinal cord, signal changes, and if you're going to operate, it's very handy to have around. But there's no agreement on what a prolapse is. There's no clinical relevance of a prolapse on MRI. It takes 2 hours at least to do an MRI scan, and doctors, if they've got a scan now, are reluctant to reduce the neck. So it doesn't have any benefit. This is from the Neurosurgical Supplement 2013. They looked at all the literature around closed reduction, and their recommendations, the use of pre-reduction MRI has not been shown to improve safety or efficacy of closed traction reduction, and they feel MRI may unnecessarily delay realignment. The Americans also think what we think, okay? It's not useful. These are the specialist procedure. We teach our medical students in 5th year how to reduce the neck. Any doctor should be able to perform safe traction reduction if and when required. The WHO, in their handbook Surgical Care in the District Hospital, they regard skull traction and tongs as essential equipment. So district hospital level procedures, not a tertiary hospital thing. So that's a Victoria Hospital, Mitchell's Plain, and Somerset, they should be doing as well. It's essential emergency equipment. Every ER and every district hospital needs a set of Cohen's calipers, and every ER doctor needs to be competent to use cervical calipers. In conclusion, most Western Cape hospitals have inadequate protocols, training, and equipment. And there's a lot of misconceptions about cervical reduction which you need to address. Any reduction of injuries is mandatory and can definitely improve neurological outcomes. So we're busy drawing up this policy document for the Western Cape, and part of it is early reduction in the SOP. And we're trying to prioritize spinal cord injuries in terms of categorizing them. This is sort of a document in evolution and needs to be signed by various authorities in Dorp Street. And we're trying to make the equipment mandatory in all district level hospitals. It should be equal to WHO, but of course, you might start different rules. And so important again, diagnosis of X-ray, early reduction, safe and effective. If you do not need MRI, we have a law saying we've got to reduce dislocations within 4 hours. Every single doctor should be competent to read an X-ray and, if required, perform cervical reduction. Thank you very much. Anybody have questions? Yes.
Yeah, I just want to find out why some patients are unreducible. Is it because of their anatomy, or because I received a patient recently that they said is unreducible C-spine from Canada?
It's a great question. So the combination of things. So it may be that the doctor hasn't used enough weight. So you want to get to at least 40 kilograms before you can say you've had a good effort. Okay. Also, if you don't flex the neck adequately, those facets, the ligaments are so strong you cannot pull. To get the facets to do that, you've got to flex it adequately. So it may be that the patient wasn't flexed properly to 30 degrees. Okay, that's another reason. And these ligaments are very strong. I did a study on looking at the pressures in the spinal cord during the dislocation. and I try to induce the dislocation in the cadaver with the boat winch. I managed to get to 400 kilograms before I dislocated the neck. So the ligaments are very, very strong. So unless you flex the neck, that's probably a reason for a failed reduction. It may also be the pins are slipped, and I think another reason is that you may have a subtle fracture of the facet, which sometimes seems to block the reduction. So about 20%, we know from literature, are not reducible. So that's a failure rate. You can accept one in 5 is going to fail. But the Concord's not going to, I think that, no one's actually put it to the test yet, but as long as you made the effort to try and reduce the neck, you tried. As far as best medical practice goes. If you don't bother, then you're going to be in trouble.
Plus, there might be a number of hospitals scattered across the country where you have access to things like the weights, the swan necks, you can get all that, but you won't be able to get a CR. Is there any possibility of giving this a go without essentially imaging?
You don't know what you're doing. So if you can do in the X-ray department, you can lie them on the X-ray, and you can take a lateral X-ray every weight if you have to. I mean, if you're going to make the diagnosis, you have another X-ray. So it's possible to put the patient in the X-ray unit and take serial X-rays. So, look, I mean, I've worked in private hospitals. There's no weights. And I've used drip bags and pillowcases. Very embarrassing. To bag of water down the patient, but you've got to do what you've got to do. So X-rays is an issue. You can argue why the hospital's even got an ER without a CR. I mean, accept that it can happen. If there's a case and I had a patient I'm going to try and reduce, I'll do it in the X-ray department. You can make a judgment call. So if a patient's an Asia E, so it's normal neurologically, and you don't have equipment and things are a bit sketchy, I think it's fairly reasonable to then phone the local centre, referral centre, Tiger or Kruger, say, this is what I have, what do you suggest? And then we'll guide you. I'll say, okay, is the ambulance there, ready to go? We'll do it here when the patient gets here. But I want to have the situation where if you phone me, you say, look, I've got a patient's Asia A, it's complete. It happened a couple of hours ago. I know it's going to take an hour to get them across minimum. I want you to try the reduction there, at least initiate it, put the cones on, start pulling. That's what I want to have. No one can criticize it. I mean, you've got to be realistic about medical care. This patient with a stabbed heart is more priority. And it's on the polytrauma. So I think it's a very cheap, inexpensive, safe way of dealing with the neck. So it's inexcusable not to have very basic equipment in place. Unfortunately, our hospital managers need to also take responsibility, not just the doctors, So they need to make sure that everyone understands quick diagnosis, the equipment's there, it's sort of maintained, that if you do have to do that one reduction a year, you can do it. That's going to cost you 19 million rand if you don't. So what do you guys think now? Do you think it's safe? Okay. Thank you very much.
Thank you.